Welcome to this ISTAP webinar. I'm Professor Karen Uzi and I'm the current president of ISTAP, and I am absolutely delighted to be chairing this event. As you know, we've already updated our best practice document, and this is our Made Easy document for you to be able to look at in a far quicker way. But what's really exciting about this is a collaboration between ISTAP, WOCN and NSWOC, which demonstrates the importance of us all working together in the prevention and management and raising awareness of skin tears, and more importantly, helping to create a world without skin tears. So this Made Easy guide, it's concise and it's accessible. And what it does, it provides a practical overview of our 2025 ISTAP Best Practice Recommendations that you will have seen, that's about preventing and managing skin tears in aged and fragile skin. So today's webinar, we have 3 speakers, and they're actually going to explore and discuss our updated definitions of skin tears, skin tear risk factors and prevention strategies, assessments and classification tools, skin tear recommendations, and appropriate wound management practices. And we're also going to be using case studies to ensure this theory and new knowledge links into practice, because that's really important. We've got Q&As throughout, so if you can place your questions and answers in the question and answer box that you'll see at the bottom of the screen, and then we will attend to those and answer as many as we can at the end of the session. And please remember that no question is a daft question. So if you're thinking about it, somebody else will be thinking about it as well. We've also got a chat box, and I've seen that many of you are already chatting in there. Let us know where you're from. So that is absolutely brilliant. So that helps with networking as well. You will have a certificate by attending this webinar as well, and that will be sent to you via email. No slides are available to be sent to you, but we are recording the webinar, excuse me, and that'll be available on the ISTAP website, which is freely available to watch within the next couple of weeks. If you're not already a member of ISTAP, please do sign up, and then you'll be able to see the video as well. The speakers we have are Holly Vance, and Holly's a program manager, a wound ostomy limb preservation in the amputation services at Harbourview Medical Centre, and she's also a member of WOCN. Corey Hershap is the president of Nurses Specialising in Wounds, Ostomy and Continence Canada. And then we have Emma Nokcheng, who is a senior specialist at the University of Western Cape, South Africa. And Emma is also our secretary of ISTAP. And we also have Ray, who is the incoming president for ISTAP, and he will commence his role next year in May. You'll be pleased to hear as well that we're using Wordly, and Wordly will help you listen to the webinar in a range of different languages, very easy to use. And once Jonathan starts playing the videos, there's a very brief overview of how to use Wordly. So please sit back, enjoy the webinar, ask as many questions as you want in the question box, keep chatting in the chat box, and we look forward to seeing you again in about 37 minutes.
This is a reminder that you can listen to today's presentation in a different language or read the captions that are auto-translated into your preferred language by scanning the QR code here on screen, or by visiting wordly.ai/join and entering today's session ID, which is KSQJ-4548.
Good day. I'm Amy Nokaneng. I'm a maxillofacial and oral surgeon by profession and based in South Africa. I'm also the secretary of the International Skin Tear Advisory Panel. I'm delighted to have this opportunity to share with you some insights on the Made Easy document, the prevention and management of skin tears in the aged skin. The Made Easy provides an overview which is based on the 2025 Best Practice Recommendations for the prevention and the management of skin tears in the aged skin. The Made Easy also supports the ISTAP's ISTAP's endeavor to have a world without skin tears. In addition, ISTAP's mission is to raise global awareness on skin tear prediction, assessment, prevention, and the management of skin tears. The Made Easy was made possible by a collaborative effort from ISTAP, ANZOC, as well as WOCN. It starts off with the updated definitions of skin tears. The skin tear has been redefined as a traumatic wound caused by mechanical forces, including the removal of adhesives and patient handling, the depth of which may vary but not extending through the subcutaneous layer. Of significance of the current definition is that it emphasizes the etiology as well as the anatomical limitation of the wound, that is the skin tear. With regards to the etiology, it recognizes the role of mechanical forces or iatrogenic forces such as patient handling and medical adhesives in the role of development of skin tears. In addition, the anatomical extent of the skin tear, it emphasizes the involvement of the different layers of the skin, but not on the thickness of the skin. The current slide shows histological slices which are derived from a young patient in A and in an aged patient in B. In both slices, the different layers of the skin are present. However, the thickness develops significantly. Therefore, in both patients, the development of skin tears is possible. The Made Easy also defines a flap in relation to skin tears, which is defined as a portion of skin, whether it be the epidermis or the dermis, that is unintentionally separated, whether it be partially or fully, from its original place due to shear, friction, or blood forces. This should not be confused with a tissue that is intentionally detached from its original place for therapeutic reasons, for example, in a skin graft. Skin tears have also been defined in relation to the healing time as uncomplicated or complicated. In uncomplicated wounds or skin tears, the wounds heal within 4 weeks or reach full epithelialization within 4 weeks. On the other hand, complicated wounds do not achieve full epithelialization within this period. The Made Easy also provides an overview on the skin tear risk factors as well as prevention strategies. The recommendations emphasize the recognition and the importance of intrinsic structural skin changes that occur in aging individuals that results in reduced tensile strength. Thus, less forces are required to result in a traumatic injury. Although the etiology of skin tear is multifactorial, a recent evidence synthesis by Chalifo in 2023 highlighted that daily living activities such as washing with cold water and soap, the lack of moisturization of the dry skin, as well as wearing of short sleeve, thus exposing the skin to mechanical forces, can result in skin tears. In addition, the wearing of jewelry by healthcare professionals or the caregivers, as well as long nails, the use of adhesive bandages, and the lack of gentle handling, as previously mentioned, can result in skin tears. Thus, it's important to have tailored evidence-based skincare that can help improve skin tear prevention, and wherever possible, the prevention should be the main aim, especially in the at-risk population. For this purpose, the ISTAP risk reduction program is recommended, which focuses on the general health, the mobility of the individual, as well as the skin integrity. Focusing on the skin integrity and preserving the patient's skin health has also been shown to reduce further types of skin damage in addition to skin tears, vastly improving the overall outcomes of the individual. The concept of bundled approach to skin tear in older people has emerged. Al-Khalifa in 2022 identified that the provision of skin care bundles to people over the age of 65 is associated with a reduction in the number of skin tears. In this study, the authors defined skincare bundles as being a set of small, straightforward, evidence-based practices or interventions, usually 3 to 5, that when performed collectively and consistently have been proven to improve patient outcomes. Identification of skin tears accurately from the first presentation onwards is vital to optimizing management. Therefore, the Made Easy makes recommendations on additional tools to facilitate the assessment of individuals with skin tears. For this purpose, the ISTAP data collection tool is recommended. Assessing the baseline skin tone is also critical, as well as in subsequent reviews or reassessments. For this purpose, the skin tone tool is recommended, which is a validated classification tool that can help assess changes in the patient's normal skin tone, reducing potential biases and improving assessment accuracy. The tool displays a range of skin colors that can match with the patient's skin tone, with the baseline determined as the tone that matches the inside of the upper arm of the patient. It should also be noted that erythema does not always appear as redness in many dark skin tones, as shown in the slide above. For consistency in the identification and documentation of skin tears, ISTAP recommends a validated classification system, such as the ISTAP classification system, where in type 1 skin tear, there is no loss of the flap, and the flap can be fully approximated on the wound bed. In type 2 skin tear, there's partial tissue loss, where the wound bed cannot be fully approximated with a flap. And in type 3, there's complete loss of the flap. Bear in mind that in some individuals may acquire multiple skin tears simultaneously. And in these instances, the individual skin tears must be classified individually. For the prevention of skin tears, the Made Easy makes recommendation on skin care program or strategies that can be used for the fragile as well as the aged skin. With regards to washing, pH balanced soaps should be used, including emollient-based products for the skin. It is recommended to avoid alcohol-based products as well as hot water. Daily moisturization, which should take place twice daily, and with the use of skin-friendly moisturizers, which are also gentle and pH balanced. Self-care is encouraged, where the individual is encouraged to manage their own skincare regimen, as well as on education of skincare practices. I will now hand over to Holly Vance, who will now talk about the appropriate wound management practices. Thank you for listening.
All right. Thanks, Emmy, for that introduction and for all that you've just taught us. I'm Holly. I am a nurse practitioner and program manager out of Seattle, Washington, a level 1 trauma and burn center. And I get to talk to you guys about the prevention and management of skin tears in aged skin. So first off, I just want to go through this slide. I really like this because it also comes to us as a decision algorithm tool on the website. So you have a shorter copy that you can reference more quickly at the bedside, and it goes into, your initial evaluation and then helping guide your goals of treatment and your treatment options for how you're going to treat a type 1, 2, or 3 skin tear. Moving on to key points here. Your aim when you're treating a skin tear with a flap, if you have one, is to preserve the flap. You also want to work on peri-wound skin protection, reducing the risk for infection and re-injury. Your initial treatment goals are to control the bleeding. You want to wash the wound really gently. You want to pat it, not wipe. If there's debris in the area or any necrotic tissue, you want to debride it if you're able to. And then other goals include managing infection and inflammation. As you're working through all of these steps, you want to make sure you're avoiding the use of sutures, staples, adhesive strips, any of these things that can cause skin to tear further or damage aged skin. So again, standard closure methods are not recommended. Additional key points here, we talked briefly about controlling the bleeding. Gentle pressure, not anything that's going to cause wiping on the skin to disrupt the flap. If you're using dressings or topical agents, see if you have access to one that can assist with hemostasis. These can include calcium alginates, cyanoacrylates. You also want to use non-adherent dressings if you can to avoid compromising the flap or re-traumatizing the tissue. Dry gauze and can dry onto that area, and so when you remove it, it can disrupt the flap or cause further trauma. So we do recommend avoiding that as well. When you're washing and debriding the area, follow your institutional protocol. Not everybody is allowed to debride without a surgical consult, and every institution kind of has their own plan in place for how and what you are using to cleanse it. So we just recommend following that. And again, I can't say it enough, pat it dry, try to avoid rubbing. You're going to remove the residual debris or hematoma in the area. Debridement is facilitating the removal of the necrotic tissue to promote healing. It also reduces bacterial colonization and improves tissue perfusion to help facilitate kind of a faster healing when possible. And if you're able to reapproximate the skin flap. At this point, this is when you can classify the skin tear after you've washed the area and been able to do a full assessment, because then you get a better idea of if the flap is reapproximatable or if it's going to necrose. So remember that type 1 does not have any skin loss and you're fully able to reapproximate the flap. Type 2 is a partial flap loss, and so it cannot be fully repositioned to cover the wound bed, but it can be partially repositioned. And then type 3 is a total flap loss. Again, you want to manage infection and inflammation. We know that inflammation is an important part of the healing process. It's a direct response to tissue injury. It helps facilitate regeneration and tissue repair. But on the flip side, infection can cause pain and delayed wound healing. It can cause swelling and increased drainage in an already somewhat wet wound. Diagnose infection based on your clinical assessment. Take appropriate steps if needed. So avoid the use of preventive, systemic, or topical antibiotics or antimicrobials unless you feel like you're seeing signs of infection. You initially may have excessive exudate, but afterwards skin tears tend to be at risk for drying out more. So you're going to want to consider moisture balance and exudate control. If there's swelling, maybe a little bit of compression can help manage that drainage, but do make sure that whatever you're choosing to do can help promote an appropriate amount of moisture to promote healing. Consider a vascular assessment of the area to rule out significant arterial disease, which can impair healing. And then if they have appropriate blood flow, consider the use of compression therapy if the skin tear is in a lower limb. Edema is often present in the lower limb of an aged individual and even a non-aged individual. It can negatively impact wound healing and slow it down because of the excessive moisture and third spacing. And so compression reduces the time to healing and improves the patient outcomes in patients with skin tears and other wounds as well. But before applying compression, it's really important that you're performing a full physical and vascular assessment. So checking pulses and skin temperature and turgor and ABIs, TBIs, if you have access to those or are able to perform those on your own. And then not just in the leg, if you feel it is safe and the appropriate assessment has been done, you can also consider it on the arm if you know how to apply it correctly. Other considerations are to select a product with the lowest level of adhesive possible for the individual needs of the patient and their wound. So again, you're going to want to avoid dressings with acrylic or rubber-based adhesives, nothing too sticky that can re-traumatize the tissue as you take it off. You want to have something that can absorb drainage easily, that it can be easily removed and applied. It's non-traumatic, it's flexible, can adapt to body contours, even around an elbow or a knee. If available, can afford extended wear time, and then of course be cost effective to the patient. Dressings that are atraumatic have contact layers built in. So you have silicone meshes, impregnated gauze mesh, lipocolloid dressings. All of these can be efficacious in healing. And then if you can leave them on for extended periods of time, even better. When you're removing them, make sure you're supporting the skin as you're taking it off piece by piece. Use a remover or a solvent to dissolve the adhesive and take it off slowly. If possible, it's helpful to draw an arrow in the direction that you want the next person to remove it so that the flap is not disrupted if they have a flap. Carefully assess whether long-term dressings are an appropriate approach to skin tear healing. So again, longer wear time can reduce the risk of contamination. There is cost savings involved in that, and it decreases clinician and patient time with dressing changes. So if you have the option to use a multi-day dressing that can stay on for an extended period of time, it is helpful in promoting healing. It is not suitable when the dressing is frequently saturated or leaking, or if there's excessive bleeding, maceration, or concern for infection, whereby you're going to need to look at it more frequently. If the dressing is lifting off, it's going to need to be removed. I wanted to include these pictures with my patient's permission here. This patient was in her 50s and has been on steroids for 20 plus years and has struggled over that time with multiple skin tears, usually caused by some type of trauma. So in this, she sent me the photo of the gate to her dog kennel. If you can see the arrow of my cursor is pointing to a jagged edge on the iron gate. She tripped over the dog and ran into the gate. and sustained this very long skin tear that was a combination of mostly type 2, but then the flaps here necrosed. So before I got to see it, she did not like the looks of it and she cut him off herself. So she did end up with a type 3 dressing. She had just been using Band-Aids and non-adhesive gauze. Had never been taught how to appropriately manage these skin tears. And so I had a silicone dressing that was formulated specifically for skin that likes to tear. And so I put it on and instructed her not to remove it for 3 to 7 days, just kind of depending on what it was doing, how much drainage was coming through. And we just additionally secured it with a gauze netting that helped hold it in place. That's her forearm. It fell over her contours really well. And then after a week, it was 50% healed, and I didn't get to see her after that. But I have not heard from her, so I'm assuming that it has healed since then. And I gave her a few extra dressings to take home should she develop further skin tears in the future. It's really important as clinicians that we're talking to our colleagues about products that should and should not be used on skin tears when we have this information. Additional cultural considerations need to be made. People might have traditional healers in their area that they work with, or community leaders that are important to the patient and help kind of guide their treatment plans. They also may prefer traditional medicines such as aloe vera plants or banana leaves. So working with the patient, meeting them at their comfort level and how they want to be treated can go a long way in getting these to heal and further prevention and management practices in the future. I would avoid iodine-based or impregnated products. Iodine can dry out the skin and the wound bed, and it is a risk factor for skin tear development because of this. This picture on the slide is a distended abdomen, and an iodine impregnated transparent film had been used as a surgical dressing with gauze to secure it in place. And the provider who did the first post-op dressing change did not use a adhesive remover and ripped the dressing off. And there is a matching skin tear on the other side of the surgical incision in this photo. It was very painful to the patient, more so than the actual incision itself. So it was really important to me to get that information to that provider, that they knew not to use that in the future, or to at least use adhesive removal if they needed. Films and hydrocolloids have an acrylic or a rubber-based adhesive that's very strong, which was meant to increase adhesion to the tissue. If it's not removed appropriately, it can contribute to medical adhesive removal skin tears or injuries, and should be avoided in this population of people with aged skin who are at risk for skin tears. Plain gauze without silicone contact layer does not adequately secure the flap, and it does increase the risk of displacement with removal. I will repeat from what I said at the beginning too, adhesive skin closure strips should be avoided. They have a risk of further traumatizing the skin because the edges can kind of lift up. They can get caught in clothing and bedding, and they can rip off on their own. Just a reminder, this is an international guideline, so any products I may have mentioned today are likely not all available in every region. You may have your own go-to products. So use your best judgment for what is available to you as you are going to treat these, keeping the best practice recommendations in mind. Thank you.
Hello everyone, and thank you for joining us for this presentation on the prevention and management of skin tears in Aged Skin Made Easy document. My name is Corey Hirschap. I'm the president of Nurses Specialized in Wound Ostomy Continence Canada and the Wound and Ostomy Clinical Nurse Specialist at Royal Victoria Regional Health Centre in Barrie, Ontario, Canada. I'll be presenting today on the prevention of skin tears in aged and fragile skin. We will review some of the content found in the Made Easy document publication, and I will relate it back to aspects of my own practice from the Canadian context. The prevention of skin tears, much like other wound types, is vital to reduce the incidence of skin tear formation, which can affect pain, quality of life, and of course, have a significant impact on our healthcare system. Prevention, as you know, is far more cost effective than treating a wound after the fact. Within Canada, for example, a 2017 study looking at 4 long-term care homes by LeBlanc et al. Found that within a 1-month period, there was a skin tear prevalence of 20.8% and an incidence of 18.9%. While Canada continues to develop a standardized approach to data collection related to wound care, this demonstrates a significant need to focus on skin tear prevention within our care settings. When looking at who's at risk for developing a skin tear, those with aging, frail skin are most at risk. As you age, your skin becomes thinner, drier, and tissue tolerance begins to decrease. When added to other factors such as significant changes to weight, whether the individual has increased bony protrusions, or if they're bariatric, which may affect mobility, these individuals are at increased risk for skin tear development. Those with dementia, agitation, and resistance care are also at a higher risk, with research being done by LeBlanc in 2017 showing that aggressive behavior was statistically associated with the formation of skin tears, with individuals being 2 to 10% more likely to develop a skin tear. Certain medications may also affect the skin, for example, causing itching or dryness, which, as we'll discuss in later slides, can lead to the formation of skin tears. Within the Made Easy document, in Table 1, there's an outline of the ISTAP risk reduction approach, providing both individual and caregiver, as well as provider recommendations for general health, mobility, and caring for the skin. As you can see, core elements of the risk reduction approach include nutritional, hydration, and environmental recommendations. Safe handling, assistive devices, and fall prevention are also included, as is the appropriate use of gentle adhesives, moisturizing, and proper hygiene. An important aspect to skin tear prevention includes considerations around washing and products used on the skin. The Made Easy publication includes information about appropriate skin cleansers, including the importance of pH balance as to prevent changes to the skin's natural acidity. The inclusion of no-rinse cleansers may also be appropriate according to the setting as well. In my own practice, we utilize a pH balanced foaming skin cleanser, which can be used bedside. We've also in the past used small bar soap, which we're in the process of changing to a pH balanced gentle gel cleanser, which is provided to those individuals able to mobilize to the shower room. In many instances, cost can become a decision factor when selecting a soap. However, when considering product multi-use, length of stay, and the improvement in skin status and prevention of wound development, the argument can certainly be made for this change. The Made Easy document also provides recommendations about the reduction of frequent hot water use, which may further dry the skin, as well as recommendations around patting dry rather than rubbing the skin dry. Another important aspect to caring for the skin to prevent skin tears includes moisturizing. Moisturizing can have a significant impact on skin tear reduction by as much as 50% if applied twice daily. The use of emollient-based and humectant products can both moisturize as well as repair and seal the skin's outer layer. The hydration of the skin's outer layer causes the cells to absorb more fluid and increase in volume, which can both reduce dry skin as well as smooth the skin. Application after bathing can assist with keeping fluid within the skin's outer layers and preventing evaporation off the skin. Unfortunately, I didn't have any images of with and without twice daily moisturizing to share. However, with the assistance of some AI, I've been able to generate an image demonstrating some of the skin changes which may occur with twice daily moisturizing, such as reduction of dry skin and increased hydration and volume in the outer layer of tissue. And you can see that in the picture to the right hand side, where in the left you'll see without moisturizing some of the more dry and creased skin, and on the right hand side an example of what you might see with twice a day moisturizer, where the skin is much more filled and moisturized. In addition to cleansing and moisturizing, there are also other mechanisms that can assist in preventing skin tears as well. Use of protective clothing, for example, can reduce the risk of skin tears should a trauma occur. Earlier, we also discussed medications and how some medications can cause itching. And should a patient's fingernails not be kept short and they begin to scratch their skin, they may also develop a skin tear. Caregivers who also keep longer fingernails are more likely to accidentally cause a skin tear should they use their fingertips to hold a patient, or if their nails come in contact with patient's skin during care. Skin tears can also be reduced through the use of adhesive removers or low adherent dressings such as silicone. In my own practice, we often utilize silicone foam dressings as well as silicone-based adhesives. And currently, we actually carry two different silicone adhesive options. When silicone foam dressings are not available to use or not being used for that patient situation, to assist with dressing adhesion to the skin, while also preventing skin damage on dressing removal, we do have those silicone adhesives. Consideration can also be given to equipment used by the patient, and this may simply be ensuring safe access to equipment. I've heard of many instances of skin tear formation when patients reach out for their walker and go to stand and have the walker leg directly in front of their own leg, and when they go to stand, it actually causes a skin tear. And that's just one example of proper utilization of equipment. On the topic of equipment consideration, also considering appropriate transfers and positioning is also important to the prevention of skin tears. I've seen many patients who've developed skin tears due to folding or pinching of the tissues when in a mechanical lift, or when being placed onto a chair or back onto the bed, not noting that the skin is being pulled against the side of the chair or a bedside rail, for example. The inclusion of an interprofessional falls prevention strategy should also be considered, given the high risk of skin tear occurrence related to patient falls. Within my own facility, we've implemented a falls prevention strategy, which includes close fall tracking, prevention planning, and the incorporation of nursing and allied health in the development of a falls prevention program. We discussed earlier how medications may cause dry or itchy skin to occur. Reviewing any of these issues with a prescriber to see if alternative options may be available can assist with skin tear reductions. We also previously discussed the importance of hydrated skin and the positive effects of hydration on skin tear prevention. In addition to moisturizers, ensuring adequate oral hydration can assist with healthy skin, less likely to develop skin tears. Previous research by Monroe et al. In 2018 has found malnutrition is independently associated with skin tear formation within the hospital inpatient setting. While age, BMI, and malnutrition were associated with skin tears on univariate analysis, only malnutrition remained an independent predictor, increasing the odds of skin tears by 63%. Finally, the education of patients and their families in monitoring skin changes and ensuring gentle skin care products, including the use of twice daily moisturizing, can reduce skin tear occurrence. The inclusion of the patient and their family members ensures more than only the formal caregiver provider is monitoring skin changes and proactively caring for the skin. In my own practice, our facilities in the process of rolling out the S-Skin and Asking framework to encourage patient and families, in addition to caregivers, are active and engaging in activities to prevent skin breakdown and enhance preventative measures, including diet, hydration, and mobility factors. Thank you all again so much for joining us today. In addition to reviewing the ISTAP Risk Reduction Program in the Made Easy Documents Table 1, I'd also recommend reviewing Figure 4, which outlines the skin tear decision algorithm, which can assist clinicians to make decisions related to the prevention of skin tears, as well as their assessment and treatment. I'll now pass things back to my colleagues for further skin tear discussion, and I look forward to hearing your questions. Thank you.
Fantastic. Thank you very much, everyone, for presenting. So quite a few questions, quite a lively discussion and debate. So the first question, by the way, I'll just mention people's first names, is from Melanie, who asks, why are steri strips no longer recommended for treating skin tears? If I come to you first, Corey, if that's okay.
Yeah, for sure. Thanks so much. So when you look in the best practice recommendation document, there's actually a section that refers specifically to the idea of like a Steri-Strip type product. And it has a number of different references in there that are fairly recent that actually talk about the potential for tissue damage on removal. And I think Holly had given a good example within her presentation of where you could actually see some of the damage caused during the actual removal of Steri-Strips. So I think given some of the newer products that we have, like the more silicone-based products that can be a little bit more skin-friendly on removal, I think the recommendation has shifted from the use of a Steri-Strip type product over to something that's a little bit more skin-friendly on removal and atraumatic.
Thanks, Corey. Emmy and Holly, I don't know if you have anything to add specifically around the use of Steri strips for skin tear treatment.
Yes, Ray, I just want to add that the use of Steri-Strip is that you adhere the Steri-Strip itself onto the flap. And the whole management with the skin tears is to avoid to cause any further damage on the flap itself. So that's why you reposition it passively, and then the dressing that you're going to use has to support that flap and not to move it around with the use of Steri-Strip, for example. Secondly, I think the use of Steri-Strip is a historical default from the surgical discipline as well, that it has been classified as a wound, but it's actually not a wound. It is supposed to support the wound incision margins, and then on top of that, you're supposed to apply a proper wound dressing. So it's not a wound dressing, it's just for support of the wound tension, and then it does not have the properties of an ideal wound dressing that would promote interactive wound healing. Thank you.
Holly, do you want to add anything?
Yeah, actually, I don't have much to add. I think they described it perfectly. But what I run into in the States, or at least in my neck of the woods, a lot of people, because Steri strips loosen fairly easily if the person is sweaty, if there's drainage in the area, if they take a shower and don't cover it, people will take iodine or benzoin tincture or something to help the Steri strip stick a little more to that area. And so you run the risk of further traumatizing it. Just it gets caught on the clothing, it gets caught in the bedding, and it will rip off. And then that skin tear is suddenly much larger than how it was started. So I just recommend avoiding it altogether as well.
Right, I'll try and get through the questions. I can see there are lots of questions about specific dressings, so I don't think we'll necessarily be able to answer all the questions about specific dressings, but a different one from Jennifer, who's asked about how best to measure a skin tear flap, whether it's full or partial thickness, particularly when a person has a crescent-shaped skin tier. I think it's about classification and our recommendations around how you should realign the skin flap before classification. So if I come to you first, Holly, if that's okay.
Sure. In the document, we actually address that by saying if you can, it's helpful to measure the flap by itself and the open area if you don't have a type 1. So you can do it separately. There is a photo in the document of one area that is a whole bunch of skin tears that gets tricky. So for specific cases like that, I usually recommend measuring just the area affected and then saying it's a combination of type 2 and 3 skin tears. However you want to, but I find it easiest to, if it's not a clear separation of flap and skin, to just measure the whole area.
Corey, do you have anything you wanted to add?
No, I think that provided a fantastic overview. And just because you had mentioned classification, I think the ISTAP classification tool that's included in the document is a fantastic resource as well in terms of the actual staging for the skin tear.
Okay. Emmy, anything to add before we move on?
Just to reemphasize that if the patient or the individual experiences multiple skin tears, then to classify each individually as a separate entity.
Fantastic. So like I said, there are a few questions about particular dressings. I'm not sure I'll be able to get to all of them, but I'll just move to a slightly different one, which is from Melanie, where she was asking about she applied an non-adhesive dressing to a wound bed. Um, an non-adhesive dressing similar to the skin tear, but she found it was still sticking, and she wondered why that could have happened. So I don't know if you had any thoughts. So I'll just repeat the question. She said she had a colleague, a resident she was looking after, who developed a skin tear after falling, and she applied a non-adhesive dressing, but she found that the non-adhesive dressing was sticking to the wound bed afterwards, and she wondered why this may have been the case. Emmy, if I come to you first.
It may be that it was too absorbent for the type of exudate that the wound was releasing. So you need to be able to align the type of absorbency of the dressing to the amount of exudate that the wound is excreting. Thank you.
Okay. Holly?
I echo Emmy's thoughts, and also even if there's just a little bit of drainage, sometimes it's just enough to dry to the non-adherent pad and stick to it.
Okay. I can see Corey's nodding, so I'll move on. And Mason, you mentioned the dressing, but I won't name the dressing here. Mason was asking if a silicone-based dressing is considered as an adhesive. If I come to you, Corey.
Um, yeah, great question. So I think that a silicone dressing is still considered an adhesive, even if it's a lighter adhesive. It really depends on where you are and how you speak about the specific dressings in your context. But I think in a lot of cases, when you think of adhesive dressings, it's usually in reference to a more adhesive dressing than your silicone type dressing. Usually, when you refer to the adhesion of a silicone, you're speaking to a lighter adhesion than you might with a standard like tape adhesive dressing. So I think that while there is a difference between silicone adhesives and other adhesives, depending on the context that you're referring to, they're still considered an adhesive. Hopefully that answers the question.
Yep, I can see everyone else is nodding, so we'll move on. And on a similar note, I think this may be one for you, Holly. There's a question from Jennifer who said, you spoke about not recommending impregnated products, and she was just looking for some clarification about why you don't recommend the use of impregnated products in treating skin tears.
Thank you for that. I think my video skipped because what I actually said was iodine impregnated dressings specifically. There are many great dressings that have other things impregnated that are appropriate to use on the skin tears. The dressing that she named in the chat is perfectly appropriate to be used. What you want to look at is to make sure that whatever it's impregnated with is not a drying agent and that you're removing it before it dries out, because more trauma can occur if the area dries out before you're able to remove it. So a lot of the impregnated dressings that I'm familiar with are indicated for 1 day of use. And so the recommendation from the panel is to keep a dressing on longer if you can, for extended wound healing. So, but that's not always appropriate. So the impregnated dressings that don't have drying agents are perfectly fine.
Just to clarify, you mentioned specifically iodine. Why specifically iodine before we move on?
It can be caustic to the tissue and cytotoxic, but also it's a drying agent. I use it specifically to dry things out. So we want to promote moist wound healing. So if we're adding iodine to it, it can cause the wound to dry out, excuse me, and the dressing to stick to it and cause further trauma.
Fantastic. And then some very specific questions. So one is from Heather, was asking, how can you remove an intravenous dressing without causing a skin tear? I think she's alluding to the fact that they're often very adhesive to the skin. So I wondered if you had any practical advice about how you might remove IV dressings. Corey, if I come to you, any thoughts?
For sure. I would say that if the patient is at very high risk for a skin tear, thinking back to the presentation talking about medication, for example, if the patient's on steroid medication, very thin, fragile skin, the use of adhesive removers may be beneficial in certain cases. Outside of that, I would just refer back to the manufacturer instructions for removal. Certain adhesives, especially film-based dressings, depending on the mechanisms for how you're removing them, can be more or less actually traumatic to the skin when you're lifting them. For example, like a pulling towards you rather than a pulling away from you can have a pretty significant impact on the patient's risk for skin tears.
Yeah, fantastic. And there's another one which I think I'll come to you, Emmy, which is what's your advice for preventing skin tears during the manipulation of fractures in people who require bone alignment to promote wound healing and repair of the bone? I don't know if you have any thoughts on that one. So it's specifically about how any recommendation to prevent skin tears when you're manipulating fractures to improve the bone alignment. Emmy, I think you're on mute. Sorry, I think you're on mute.
The question is prevention of skin tears while you are mobilizing fractures.
Yes, that's right. Yeah, that's right.
Okay, off the cuff. The I normally advise using gentle manipulation, for example, so that and wearing of silicone gloves. Obviously, you should be wearing gloves when you're manipulating such fractures to prevent to prevent infection. Be gentle in the way that you are manipulating and how you handle the skin. And quite often, I also like to not moisturize, just to wet the skin a little bit before you start handling the patient. So I'm not sure whether any of my colleagues have anything more to add to that. But it's important to be very gentle.
Corey, I don't know if you have anything you wanted to add.
No, I think that's a fantastic answer. And I would just recommend, especially when you're talking about the actual manipulation as well, considering where the patient is physically located and some of the equipment and the things like even the patient's bed sheets. So making sure that when you're moving the patient, making sure that underneath there's not a lot of creases, folds, that things are nice and smooth, and know where to catch the patient's skin when you're actually doing the manipulation.
Yeah, I have a thought as well, Emmy. I wasn't going to answer questions, but I think it's also important to assess the risk of the patient. So before you start manipulating the fractures, having a sense of what their risk factors are and what their skin looks like. And if you have
Yeah.
particular concerns about their skin, I think the first place is to try and moisturize the skin as much as you can. But also in terms of the actual pressure and force you apply to the wound, it's important to take that into account. And other things that you normally do as well anyway, like ensuring there's adequate pain relief. Because again, if someone's going
Yes,
to be
Paul.
resisting you, that's going to
Yeah.
cause additional issues. So a rather complicated answer, but I think we've
Yeah.
kind of got there in the end. Then there's some other fresh questions which have come in, so I'll go through them very quickly, and everyone can answer these. So the first one is, do you recommend the use of tissue glues? I think they're also called cyanoacrylates for category one skin tears rather than using a dressing. So I don't know who wants to take that one.
I'll take that.
Okay.
I don't recommend it for skin tears because they're not really classified as interactive dressing. Remember, the principles of wound healing must still be applied to skin tears as well. So you want to have a dressing that is going to encourage moisture in that environment, as well as not be too absorbent so that it doesn't, it forms excessive scabbing. With cyanoacrylate, you don't get that. I tend to use it for children, although not in skin tears and lacerations on that, because I'm avoiding the use of removal of sutures, which in skin tears you would not want to do. You don't want to use sutures and so because you're going to cause further damage on that. So in a nutshell, they would not be recommended in a skin tear.
Fantastic. So I can see there are a few questions that people are asking about the recording. So I understand the recording will be available after a week on the ISTAP website. So yet another reason for you to sign up for ISTAP. Then there's another question which has just come in from Mailer, which is about how long do you recommend we keep a dressing in place on a skin tear? And she goes on to say we normally keep it in place for a week. So if I come to you, Holly, how long is an ideal time to keep the dressing in place?
Yeah, that's a great question. It's also going to be specific to the manufacturer of the dressing that you're using. So if you have a dressing available that can stay on for a week, that's great. If it can stay on without getting too wet, then absolutely a week is great because it's undisturbed wound healing. That's what the UWH in my slide stood for. Um, so the longer you can keep it on, the better for the wound environment itself because it's undisturbed. The pH isn't being messed with, the moisture balance isn't being messed with, and so it can allow the area to heal without a little bit, without more disruption from daily dressings. But again, it's going to depend on what you have available to you and the recommendation of the manufacturer of the dressing that you want to use.
Fantastic. So, lively debate. Lots of questions about acrylic dressings. I'll come to you, Corey. So, a few people have asked if you can talk about the use of acrylic dressings and whether they're appropriate to use as a treatment method for skin tears.
Good question. I think that there's definitely a role. Rather than speaking to any one specific dressing, I know one of the benefits to the use of an acrylic a lot is the ability to visually assess the wound. That and the ability to absorb small amounts of moisture. So there's definitely some positive aspects to their use, but I wouldn't say that it would be your only option or the best option. And I think that there's certainly opportunities for where it would be beneficial. And then other opportunities where you would have to look at alternative dressings. And I think it speaks to looking at that specific wound, doing a full wound assessment and considering things like exudate management, bacterial load, and all your standard wound assessment techniques that would allow you to make a proper decision.
Right. So, almost at the end. So, just two questions to finish. So, the first one is a question from Cecilia who's asked, do the principles of preventing and managing skin tears also apply to Marcy? Marcy as well. So, Emmy, I can see you nodding. Do you want to answer that question?
Yes, in a nutshell, they do, because uh, Marcy is also a type of a skin tear. So to be able to prevent Marcy, the same principles will apply.
Right. So the very last question from anonymous attendee who said they work in the ambulance service and their wound care is provided by specialist practitioners who often respond after the initial response from the ambulance. So what would you recommend that the ambulance crew apply to skin tears, apart from what they normally have, which is just gauze or field dressing, while they're waiting for specialist management? Because often for them, there's a long delay between them bringing someone to hospital and the patient then being able to access specialist care. I'll come to you, Holly, because you're nodding along. So this is our last question.
I really appreciate this question because everybody, ha only has so much options available to them for what to dress with. So in this case, gauze and field dressings are appropriate for your ambulance-based services, but what would be helpful to the practitioners coming after you is if on the tape you draw that arrow in the direction that the skin flap is sitting, if there are skin flaps, so that they know how to remove the dressing. I know when I come down to the ER or on the unit to see a dressing like this that's been on for quite a while, I'll often have to get it wet and use the adhesive remover to take it off. And it is always helpful if there's an arrow on the dressing to tell me which direction the flap is sitting so that when I take it off, I'm following it so I'm not disrupting the flap if at all possible.
If I may just add, Holly, I always suggest that they also moisten the gauze first before they put it on the dressing and then cover it with whatever they're going to cover it. So that that moisture provides some form of moisture, but it also prevents it from adhering to the flap.
Thank you, everyone. So I can see there are more questions, but unfortunately we've run out of time. But what we'll do is we'll make a note of the questions that we haven't answered. So we'll post the answers on the ISTAP website. So thank you very much for your time and for joining us. And thank you also to Emmy, Corey, and Holly for answering our questions. So if I hand back to you, Karen, for the final words.
Just to echo what you said, Ray. Thank you to all the people that are on the call. You've been absolutely brilliant. Loads of chats, very interactive, lots of brilliant questions as well. And it's also nice to hear paramedics asking questions as well, because skin tears, you're often the first point of contact, as are the pharmacists as well. So it's not just a nursing role. And what's really important is that we educate patients and carers as well about moisturising and looking after their own skin and preventing bangs and trips within the house. And one quick word is that Steri-Strips, remember, is the maker's name, so it's wound closure strip. So it's more than just a Steri-Strip that you don't want to be putting onto a wound. But Ray, that's it from me, and thank you to everybody.